My name is Casey Umland. I'm the program director here at the Y, and it's my pleasure to welcome you all. Honestly, I'm really excited about the turnout. I'm sorry it's 1,000,000 degrees in here. We have advanced technology at the University of YMCA very far, but not to the point of central air conditioning. We'll all sort of bear through it, and we're really excited to have you here. For the intersection of culture, language, and healthcare in Maya Guatemala, we're especially excited about this because it's sort of the first kickoff event in our partnership with the Global Health Initiative, which is one of 5 new international programming projects that the Y is doing, and you'll hear more about that as the year goes on. Since we're a fairly small group, we're going to forego passing around a microphone for question and answer, which I've been promised there will be plenty of time for. So if you have a question, just raise your hand and we'll let Peter sort of point at you and just speak up so that we can hear you. As with any lecture at the Y, the views expressed by Mr. Roloff are not necessarily ours. And if you need to leave at any time during the presentation for any reason, please feel free to discreetly slip out. And with that, I will introduce Greg Damhorst, who's with the Global Health Initiative, to introduce today's speaker.
Thanks. All right, well, first of all, thanks for coming, everyone. And for those of you who don't know me, my name is Greg Damhorst. I'm an MD PhD student here at the University of Illinois and also one of the students leading the Global Health Initiative. Our setting here at the Y is fitting today because the Global Health Initiative, which is sponsoring Peter's talk today, is just setting out in a new partnership with the YMCA where we'll be exploring the idea of an international partnership centered around global health themes. More of that will come in the future. If you are not on our mailing list or want to get involved in this global health community on campus, stop by and see me at the end of the talk today and we can get you on our email list. My task is to introduce Peter here. Just briefly, Peter Roloff directs WUKU Kwok's medical programs and provides guidance, leadership, oversight, and quality assurance for medical protocols, staff, and patients. He also plays a key role in strategic planning for the organization. He holds doctorates in pathobiology and medicine. He's been managing clinical programs in Guatemala since 2002. He's a physician in the Department of Global Health and Social Medicine at Harvard Medical School. And his research interests in Guatemala include ethnomedicine, cultural revitalization, resource poor healthcare management. He speaks several languages, and he's also an alum of the Medical Scholars Program here in Urbana. So without further ado, I'll turn it over to Peter.
Thanks. It's a pleasure to be back in Illinois. I was an MD PhD student here, and so I was in Illinois, in Central Illinois for about 10 years. Recognized several familiar faces in the audience, so it's nice to be back. I got off the plane Monday night in Chicago and was welcomed by that warm, muddy Central Illinois embrace, that you don't get anywhere else in the world. So it's quite nice to be back. So what I want to do today is just talk a little bit about the work that we're doing in Guatemala. Not really the specifics of the work per se, but more about what is it about Guatemala that's so compelling, and what can we learn about, I think, global health needs and in general from the Guatemala case, and sort of what it means for the way we do development or advocacy or whatever it is we do in our professions or our avocations. So that's the plan. I'll try. I heard the sort of vaguely concealed threat to leave plenty of time for questions, so I'll try to be concise and not ramble on too much. There we are. So I'm going to start with just one example of why Guatemala is an interesting place to work. I could have picked out of many dozens of examples, but this is potentially one of the most compelling. This is a map of Central America. The white part up on your upper left is the Yucatan Peninsula of Mexico, and of course the white part down on your lower right is South America, so there's Central America all there. And this is a map produced by the Institution of Nutrition of Central America and Canada that's supposed to show where child malnutrition is in Guatemala. I apologize that none of this stuff is available in English. And the redder is the more child malnutrition there is. And so that big, thick, ugly, horizontal, dark red strip up in your upper left-hand corner is the Central Highlands of Guatemala, which is where all the malnutrition in Central America essentially is concentrated. And that's where all the indigenous people in Guatemala live. So there's a close mapping in Guatemala of being malnourished, being a sick child, and being an indigenous child. In fact, Guatemala has the highest rates of child malnutrition in the entire Western Hemisphere. I would say worse than Haiti, because everyone thinks about Haiti as being the most depressed, difficult place in the Western Hemisphere to work. But in point of fact, Guatemala has the worst child malnutrition rate in the entire Western Hemisphere, and the fourth worst child malnutrition rate in the entire world. And the only places in the world that have more malnutrition than Guatemala are places in sub-Saharan Africa that are ravaged by civil war and HIV. So why is Guatemala so depressed, and why is child health in Guatemala so poor? This is just an example of, this is the only technical slide I have in my entire presentation, so don't worry too much. This is a graphical representation of one of the communities I work in Guatemala. And the white bars in this graph are the weights, actually, of these children under 5 years old in this community. 0, right there in the middle of the graph on the x-axis, is normal weight. And you can see the sort of bell curve spreading out around 0. So this is a population of children that have basically normal weight. The blue bars on the hand are the heights of these same children. And you can see that the heights of these children are shifted way, 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 way to the negative side of this axis. So these are children who are very, very, very short while still being relatively normal weighted. There's a type of malnutrition called stunting. It's a really interesting type of malnutrition. It's the type of malnutrition that's most common in the world, with about 200 million people, children, in developing countries around the world suffering from stunting. It's way more common than the kind of malnutrition that makes the news, like the baby with the swollen belly, lethargic, with the eyes sort of buzzing, with flies sort of buzzing around the eyes. That's a serious problem, not nearly as prevalent as this kind of malnutrition, stunting. And Guatemala is, for better or worse, mostly for worse, the epicenter of this type of stunting in the Americas. So people always say in Guatemala, at least, Guatemala being a country that's mostly indigenous Maya, but ruled since the Spanish conquest by first Spanish European elites and then their sort of New World successors in the modern Guatemalan state by a small elite non-indigenous minority rather. So policy in Guatemala has always said that, well, this is not, your graphs are all well and good, but the bottom line is that they're just Indians, and they're short because they're Indians, right? If they weren't of sort of Maya stock, they would be taller. But this is in fact not at all the case. This is a project that we participated in 4 or 5 years ago with the ABC. These are all Quiche-speaking Maya children, and the ones on your left-hand side, or the ones against the orange wall, are children born and raised in a Quiche-speaking community in Guatemala. And above their heads is a blue line that traces the 50th percentile for where children should be in terms of their height at 9 years of age. All these children are 9 years old. And the children on the right, on your right, are from the same community, but they live in southern Florida. And they were, their parents were fled during the Civil War in the 1980s. Their mothers got pregnant in southern Florida, had prenatal care in southern Florida, gave birth to their children in southern Florida, and raised their children with access to pediatric care and nutrition in Florida. And they're all 9 years old, all of these children. And you can see that the ones on your right all sort of touch that line. Right? In other words, there's nothing about being Indian that makes you short. It's just about not having access to health care and being marginalized and being discriminated against. And so sort of effectively here with this photo we can reject the entire sort of neo-biological racism that undergirds the justification of maintaining a large percentage of this population in poverty and sickness. So what I'm trying to do just with this little vignette about child malnutrition is just sort of sketch out how illness in Guatemala maps really closely to indigeneity. So if you're Maya, you're much more likely to be sick. It's not just about health, but it's about other things as well. If you're Maya, you're less likely to have a job, you're less likely to finish school, and all that stuff. So this is a sort of a map of Guatemala in the bordering parts of Mexico, taken from the most authoritative source of all knowledge in the world, Wikipedia. And I like this map a lot because this map is sort of is the way I think about Guatemala. And what you see sort of dispersed over this map here, Guatemala being sort of right in the middle there, where all the pink words are and the blue words. And then as well the bordering part of Mexico, the Yucatan Peninsula up at your top. And then to your left, that's Chiapas, the state of Chiapas. These are all the Mayan languages that are spoken in this part of the world. You can see that there are a lot of them, all kind of crammed in there. In Guatemala, in point of fact, there are more than 20 Mayan languages that are spoken. And the size of the word is sort of supposed to represent, how many speakers of the language there are. But there are 4 big languages anyway in Guatemala: Quiche, Cachiquel, Quechua, and Mam, all of which have upwards of 500,000 speakers. Quiche has probably 1.5 million speakers. So these are not languages that are small or sort of fiddly by any sort of stretch of imagination. They're big, robust languages with tons and tons of speakers. And this is also, if you recall, exactly where that ugly horizontal red strip is, right? Where all the child malnutrition is. So where people speak Mayan languages is also where all the kids are sick. So there's a very strong correlation here between being Maya and being unwell. The interesting thing about Guatemala, and this applies also to Chiapas and less potentially to the Yucatan Peninsula, is that despite the fact that a large majority of the population speak these languages, they don't really have access to any healthcare services or any services at all, legal services or education, although education has made some slight progress. There's now this primary school bilingual education in Guatemala and most Mayan languages, although the point of bilingual education is mostly assimilationist. You go to school monolingual in Mayan language, and by God, by the time you finish primary school, you had better be speaking Spanish so that you can go on to, a proper education. So there are no services in these languages. And I think this is a problem, but the Maya, at least my patients, also think this is a problem. I'm going to play this little video for you here, hopefully. I know this is kind of a cruddy outline, but I'm not very technically savvy. So this woman is a patient of mine that I've known for about 10 years. And she's going to tell you why it sucks to be Maya. And the subtitles should sort of be below. And then I'll summarize at the end in case you can't really read it. Hopefully the sound will be okay.
Escucha Castilla. No como te quedas tratando con el idioma más. Caso de mongoticas, se requiere mucho de que quiere, se requiere mongoticas. Pero es más raro de escapa, que tiene un banalidad, pero quiero mongoticas también para llevar. أتكلم عن أشياء تقدير، أتكلم في مجال التحليل، بس كي يوم لو كترش عن شغل تقدير، إيه هم قدرت، إيه هم تشيخ تقدير. إذا كان إيه مستعد بالنهار، بس كبدأ بالتوشين نسينا تسرائيل، بعد كذا إيه فهمت؟ هتسرائيل أقول من نوع البلد، فليش نوع؟ Siempre quisiera agradecer y Mateos.
So I've been showing this video for like 10 years, so I apologize if some of you have seen it already. But obviously this is a sort of very highly stylized encounter because we are working with this community to develop some healthcare services. She's speaking Cachiquel, which is one of the big Mayan languages. We're working with her community to sort of help develop some Cachiquel language medical services. So she obviously has an opinion about this, right? She thinks it's a good idea. So she's thanking us at the end. But that's not the point of the video. The point of the video is the sort of central anecdote here, which is about how frustrating it is to go into a clinical encounter and know in advance that the doctor you're seeing or the nurse or whoever it happens to be is not going to understand anything you say because they don't speak your language. And you're not going to understand anything they say. And you're going to be really embarrassed to talk to them. And they're going to be really irritated at you for coming. And then in the end, you're going to pay them like a consultation for 30 minutes of mutual unintelligibility. And so this is the sort of daily lived experience of all Maya everywhere in Guatemala, and we sort of wonder why their healthcare outcomes are not very good. And so there's, I started with child malnutrition as the example that sort of is most, perhaps potentially most pressing, but there are numerous encounters with numerous disease conditions in central Guatemala that I have on a daily basis that all sort of point to language barriers, cultural unintelligibility as being core to the lived Maya experience of illness and their illness narratives on a daily basis. And so here, of course, this is a diabetic patient, so this is in the context of developing a program for adults with type 2 diabetes. So this is not just about moms and babies, this is also about old people, middle-aged people, and diseases of all kinds. And so this is sort of my little graphical representation of what happens when a patient goes into one of these encounters with a Guatemalan physician or Guatemalan provider. I think maybe the projector turned on. The projector overheats.
But it also has 100 degrees.
So anyway, there's this phrase in Kachikal Maya, which is one of the Maya languages that I speak well. So it's the language I refer to most. There's this phrase in this sort of like chorus in Kachikal Maya, Rochok Maya Och Mestankan, like we are the Maya and we are forgotten. It's a sort of very common refrain that sort of almost like a dicho, like a proverb, that's sort of repeated over and over again in the clinical encounters we have with patients. And so imagine what it's like. Just imagine that you're sort of poor and you live in this sort of fractured, dysfunctional social landscape where there's no food and there's no work and there's no education and there's no access to anything. And as we know, sort of thinking about illness as a social construct, people get sick not purely for some biological reason. And in fact, most biological reasons have these social determinants. So, why does a patient become diabetic? A patient becomes diabetic because they don't have any land anymore because their land was stolen from them, and so they don't have any way to grow fresh fruits and vegetables, and so they eat, crappy food that they buy in the store, and then they get overweight, and that leads to diabetes. Or, as we were talking about yesterday in the medical grand rounds, it's very clear from longitudinal data that children who are malnourished become adults with diabetes. So the shock, the insult of being a sick child actually programs the body in new ways that predispose you to being diabetic. Or, moms are anemic because they don't have access to prenatal vitamins, and so their babies are born with low birth weight, and then their babies are malnourished and sick, right? So almost all of the things that we can conceive of as causing illness are in fact not pure biological mechanisms, right? They're the mechanisms that are embedded in the fabric of the social structure and of systematic injustice. So imagine you as the ill person, illness being sort of the final common pathway of your experience of being discriminated against and marginalized, go into the clinical encounter, go to see the doctor, hoping to find some relief for your decades-long experience of social injustice, now manifesting as physical illness, and you can't speak to the doctor because you don't share the same language. Imagine how that feels to you, bringing with you all you do, all your experience of lived injustice, and also like decades of frank, overt political oppression and civil war. And then imagine the doctor or the social worker or the nurse also being very frustrated because they don't share this culture or this language. And so rather than sort of reflecting on what it is that's concretely causing the miscommunication, which is a language barrier primarily, they say, well, this patient is non-compliant, this patient is ignorant, this patient is in India, and they're lazy, they're unmotivated, they're backwards. If only they would be proud to be a modern Guatemalan citizen and participate in all that modern Guatemalan state has to offer, they would no longer be so sick and backwards, right? And so the cycle that's initiated by mutual unintelligibility across the language barrier, sets up this vicious cycle of blaming patients and patients being unwilling to talk to providers. And this is the cycle that we have to break. So, we in Wukukawuk Maya Health Alliance, which I've been working with for almost a decade now, we have been trying hard over the last 10 years to develop primary care systems in Guatemala that more than anything provide medical care in Mayan language. So we do other things as well, but really that's the thing that we think is essential here. Let's break this vicious circle of missed opportunity for communication and compassion. And let's do this by as the doctors or as the healthcare providers or as the social service agency, just admitting that we should probably move closer to our patients and learn their damn language. Right? So it's not that hard. And when you ask patients why, in the early days when we started doing this, we did some interviews with some community leaders. We asked patients why is it important for you to have medical services in your own language? Okay, this is a stupid question, right? Of course, we all know the answer. The answer is so that I can talk to the doctor about what's wrong with me. Okay, so that turns out to be the number one reason, of course, that people say, well, I should be able to talk to the doctor. The patient should be able to easily communicate with the doctor. But there's this other reason, which in our survey, our needs assessment surveys, was number 2 reason why patients and community leaders said that you should be a doctor who speaks Kachikal, or you should be a healthcare organization that provides services in Mayan languages, is that this phrase, so people were basically saying to us, you should be providing medical care in our language so that we don't lose our words. That's literally what that phrase means. Sort of redacted this to say active maintenance and recovery speech. But the point here is that the most surprising and important finding for us in the work that we've been doing over the last 10 years is that patients and communities value, of course, medical care in their own language for all of the obvious reasons, but they also value it for reasons that are, at least on the surface, maybe not so intuitive. That they recognize that medicine is a critical site of struggle in the maintenance of their own culture. And it's a high symbolic exchange, high status exchange, in which if one were only able, finally, to talk about one's illness with a doctor, a high status individual, and an individual at the top of the technical social ladder, in one's own language, that would say a lot about the vitality and validity of that language, and by extension, the culture that births that language. And so our patients at least recognize that when we provide together, it's not just doctors doing this is a community-based interaction. When we provide medical services in Mayan languages, we are in fact standing up to, in a way, in a very highly symbolic way, the centuries of marginalization that these languages and these cultures have been submitted to. And we are having effects on the language, and we are having effects on the culture that are more than just keeping people alive. Although that is, sort of clearly, as a physician, number one. We are also keeping the language alive, and we are keeping the culture alive, because we are saying this language and the thought that it conveys is valuable enough and important enough and technical enough, complex enough to convey all of the nuances of your illness narrative. This is very, very important. And we can think about this from the sort of reverse side too, right? So, if we think about it as I sort of described in my little circle here, if we think about language barriers and people who are indigenous are sick because they're indigenous, what does that mean? It means in large part that they speak a language other than Spanish, therefore they can't access care in their own language, therefore they're sick. That's certainly part of it. I'm being a little reductivist, obviously, here, because indigenous people are also rural people. There's sort of other things going on other than just being indigenous, but in a country like Guatemala, at least, where 80% of the population is indigenous, you can make this strong case. there's more to this than this. So let's think about this from the reverse. So assume, as you may imagine, being Maya anywhere really in the last 500 years, and trying to think about how to protect your children from poor health or whatever. Let's imagine you say, well, it's obvious that my language is discriminated against, that my culture is discriminated against, so therefore I will stop teaching my children my language. And I will stop sharing my culture with my children because it's better for them to assimilate into the dominant, although minority, the dominant Spanish language culture or the dominant non-Indigenous culture, because that means that at least they will be healthy and they won't die and they will have a good education. And this you see over the last 500 years. It's especially acute in Guatemala since the advent of the Civil War, sort of late 60s up into the 1990s, where parents, basically indigenous parents, totally stop speaking to their children in Mayan languages. And this basically affects 2 generations of Mayan children through the Civil War, because they don't want them to suffer the same oppression, whether that be like literally knocked on the door, drug away, and assassinated, and thrown into the ditch in the middle of the night, or having your hand slapped by a ruler for coming to first grade and not speaking Spanish by a teacher in a public school. All of these are the narratives that we hear. The problem is that this is in fact not the case. So yes, it makes sense as sort of a concept. Let me protect my children from discrimination and death. Therefore, let me not share my culture with them. But historically, this isn't actually successful, right? Because there's an enormous sort of glass ceiling, if you will, in Guatemala, where it doesn't really matter whether you speak a Mayan language or not, or whether you wear traditional Mayan clothing or not, because if you look Mayan, you'll damn be discriminated against. And so what you have is 2 generations of Maya who have intentionally stopped teaching their language to their children in the hopes of guaranteeing their children a better future. And in fact, what they end up is instead of being poor in Maya and sick, they end up being poor in non-Maya, but looking Maya and sick. And so, in fact, all they do is lose their culture and lose their language, and they're still in exactly the same place. So it's this horrible, horrible double bind, where you basically have a choice between being sick and being indigenous, and being sick and looking indigenous. Right? And in many ways, the second option is much worse, because through the process of assimilation and acculturalization, you've lost the only thing you potentially had, which was at least the support of your community. So 2 generations of Maya experimented with this and failed to rise through the oppression which prevents them from scaling the social ladder because literally of their physical appearance. So the only way to fix this problem is to reverse this perverse dynamic that forces parents and communities to choose between living and dying and not having anything to live for. So I'm Maya. I give up my heritage because I think maybe that will give me a little bit of an edge. I'll be less likely to be rejected when I go to the hospital gate by the security guard who won't open the door because I'm wearing trape. So I'm more likely to maybe more likely not to die, but now I will have nothing worth living for. So the solution, and this is sort of the Wuku philosophy here that we've been trying to explore and trying to articulate in Guatemala, is the only possible solution to this problem is to reverse this dynamic. And the way you do that is you create institutions that support Maya-ness in its full complexity. And we've been trying to do this by leveraging our experience in medicine. So we can at least create a primary healthcare system that's fully Maya from top to bottom, that supports Maya culture, that supports Maya language, and that as a result provides better healthcare by providing people access to things they care about in ways that they care about them with a tone and a vibe that's Maya, healthcare outcomes improve. There's also sort of more to this. I think this is just sort of a linguistic aside, but I think it's kind of interesting. If we think about this sort of cycle that I showed at the beginning, where patients don't do what doctors tell them to do, largely because they don't understand what's going on. And then we think about the way public health agencies and ministries of health and international health organizations and non-governmental organizations and everyone else feeds that back on the Maya into this blame game. Well, you're just stupid and you're in India, and that's why you don't want to do what I know as the healthcare expert that you should do. The best examples here are with moms, right? So, babies might be sick because healthcare, because food prices over the last decade have tripled because of the ethanol subsidy in Illinois, or they may be sick because, there's no clean water anywhere. But rather than, having the political will to address international commodities trading policy, or the political will to put in, really develop community-based water and sanitation infrastructure, why don't we just demand that all pregnant women, or all lactating women, nurse their babies exclusively until 6 months of age? Because it's easier to expend the biological capital of an indigenous woman than it is to fix the social structures that actually undergird child illness. And so rather than say, oh, your baby is sick because you don't have access to clean water because food is too expensive, we say your baby is sick because you as the mother failed to nurse them as I told you should, dad, mother. Right? So this dynamic of blame is really the whole field of behavior change, right? So if only the Indians, I'm using this word sort of in this very intentional, I know it's an offensive word, but this is the way the word is used. If only the Indians would do what the public health experts told them to do, like feed their babies like we tell them, and nurse their babies like we tell them, and wash their hands like we tell them, and boil their water like we tell them. In fact, everything would be just better. So part of this, of course, part of the reason why this dynamic is wrong is because it neglects the ways in which people are underempowered to make rational choices in their own lives. If your agency as an indigenous person is restricted by endemic and crucifying poverty, it's sort of hard to, make the choices that people who have more economic power or social capital can make. But it's also a linguistic problem, and this is sort of, I just want to, because this is supposed to be a talk about language, I also want to focus on this. So how many times have we had in our clinical encounters a patient come into our clinic? This is literally a daily occurrence. Say a diabetic patient comes into our clinic, and typically the patient has been bouncing around the healthcare system for 10 years and has seen dozens of doctors and dozens of, curanderos and lots of different healthcare encounters, all trying to cure their diabetes, which is this disease that they don't really understand. Because when they go into the healthcare encounter with the doctor, they say, well, I don't know, I'm peeing a lot and my vision's a little blurry and I've lost some weight and I don't feel very well. And they're speaking in Maya and the doctor is shouting at them in Spanish. You can imagine how these encounters go. I know this all sounds ridiculous and hyperbolic, but it is not. I'm not being hyperbolic at all here. This is really the way these healthcare encounters go. And so the patient is going, and you heard my patient in the video say it, and the doctor says, what did you say? What did you say? And she's like trying to communicate with the doctor, and it's not going anywhere. And so she's trying to tell him what's wrong, and my bones ache, and I'm losing weight, and I don't have any appetite. And the doctor is shouting back at her in Spanish, and she can't understand a single word. But there's this phrase that keeps sort of popping up in this like noise that is Spanish that she doesn't understand, which is like diabetes. So she just keeps hearing this like string of 4 syllables, diabetes. Well, what is this? Well, I don't know what it is. It's this random string of Spanish noise, but that must be what's wrong with me. So then she comes to my clinic and she says, oh, well, I want to see this guy. I didn't understand anything he said, but he kept saying this thing, diabetes. What is it? I don't know what that is. Well, what that is diabetes, right? It's this like foreign string of Spanish words that's being shouted at her by a physician that doesn't share the same language with her. And so, you just say, oh, so you mean you have right? You have this condition in which your blood is sweet or whatever. We use sort of anthropomorphized terms here in modern languages. But, so that's what that means. oh, so that's why all that shouting about what I was eating, oh, that makes sense now, right? So why was this patient so stubborn and non-compliant? She wasn't stubborn and non-compliant because she's an idiot, right? She's a rational human being like all the rest of us. She's stubborn and non-compliant because she didn't understand anything the person was saying. Right? It's very straightforward. Right? So doing culture work and doing language work and meeting people where they are, both at their educational level and at the linguistic level, is the solution to the whole problem of patient non-compliance. So I know this sounds so ridiculously simple and straightforward, and it is, but nevertheless, this is the environment we're in where these things are not valued. Okay, so I won't go on too much longer because I just wanted to sort of just throw out a couple ideas and then have you guys tell me what you think. So why does civil society matter? What I mean by civil society is why do non-governmental organizations, church groups, missionaries, charity organizations, philanthropy, why does all this matter? Well, this matters for one really particular concrete reason in Guatemala. It matters because since the Civil War, the presence of private capital, charitable endeavors in Guatemala has blossomed in this way that is totally indescribable. So in 1990, before the end of the Civil War, there were about 1,000 non-governmental charitable organizations working in Guatemala. In the mid-2000s, there were more than 10,000 non-governmental organizations working in Guatemala, and that number now is at about 15,000. So there has been this absolutely unimaginable explosion of private capital and charitable work in Guatemala over the last 15 years. I want to compare this to like Bolivia, so I put Bolivia there in the gray bars over the same time period. The reason it's important is because Bolivia has a sort of, as you guys know, probably better than I, since all I do is go to Guatemala and think about anything else. Bolivia has a relatively progressive, leftist, pro-indigenous government, which also sort of nationalist and has restricted, in some ways, the flow of privatization. Although there were all those scandals about water privatization, a decade ago in Bolivia. But nevertheless, Bolivia has sort of kept the brakes on the sort of neoliberal influx of private capital. Guatemala has embraced it. The Central American Free Trade Agreement, deregulation of the sort of public-private interface, and outsourcing of basically the entire Ministry of Health has led to a situation in which non-governmental organizations and charity groups now are basically doing all the development work in rural settings. So this matters because that means that's us, okay? And it matters because whereas 15 years ago, 20 years ago, we might be able to say, well, the reason that indigenous people in Guatemala are marginalized and losing their languages and their cultures because the government doesn't care about indigenous people. That is not actually the case anymore, although not that the government cares per se, but that the government has decided that it doesn't need to care. So the Constitution of Guatemala now guarantees equal access, equal rights to indigenous people, et cetera, et cetera, et cetera. Whether that's the case or not, on paper there is a law. It doesn't matter because all that rural healthcare stuff has, that bothersome trekking around in the woods and in the fields has been outsourced to us. So now non-governmental organizations and charity groups and church groups are the people who are interfacing with the indigenous population. So that means that if these languages are dying or these cultures are dying, it's our fault. And this is in fact the case. Even the best intentioned and the most well-meaning development organizations in Guatemala lack the experience and the capacity to build true valuation of indigenous languages and cultures into their programs. We see this over and over and over again, where it's more important to put in water filters, and we got to do it quick. And it would be nice to be able to talk to people in Cachiquel or whatever, but that's not really our core, so let's focus on our core. And you hear this sort of over and over and over again. And the result is, I submit, that development in Guatemala now is the primary driver of language death. It's not the government, it's not the military, it's us. it's all of the Germans and the French people and the English-speaking people from North America and the United Kingdom that go to Guatemala and try to do good things and do it in this sort of quick, slap-happy, jury-rigged way, that are teaching indigenous children now. Not only is it important that you continue to suck up to people from other countries, but now you not only have to learn Spanish, but you don't speak Spanish either, so you probably have to learn English or German or French. So we are adding another layer of linguistic discrimination onto these rural communities by our very presence and by our very attempts to engage them and help them. Often, ironically, with a very pro-indigenous message, right? So it's very troubling. I think I'm going to stop there because I think it'd be more interesting to have questions, and I wanted to keep this intentionally sort of on the brief side. This is one of the communities that I work in. This is one of my buddies, my child. Here we are doing a little nutrition class with some of them in one of our communities. So thanks. Let's see what you guys think about this. Whether it's useful, interesting. Am I wrong? What does this bring up for you?
Missionary people coming in, and if you found that another hurdle for you, or in any way okay, or is it another example of affecting the culture with missions? Yes.
Yeah, I think missions. Of course, missions to Guatemala are so high volume. Many of you have been to Guatemala. I'm sure many of you have. Many of you who have been to Guatemala have been on that plane with those 35 kids all wearing a white T-shirt with the blue lettering that says, Campus Crusade for Christ, Guatemala 2012, right? You've all been there. So it's an enormous industry, and the reason it's so enormous is because it's an enormous cash cow. So you can charge kids a lot of money, go to Guatemala for 2 weeks and, move dirt around a field, or dig holes in the ground, or whatever it is they do. And I think it's part of there are two things going on there. It's part of the overall overwhelming of the indigenous communities by foreigners that are unskilled and uncommitted. And there's sort of a mutual exploitation going on here, right? Because clearly if someone can come down and, I don't know, bring enough money to build a school or build a wall or I don't know, whatever it is they do, and the community is getting something out of it. Right? And this is the problem, is that it's not that these short-term groups provide no value or no services. They often do provide some value or some services. But the question is at what cost? And the cost is culture, I think. Because children in these communities, in their repeated engagements with these organizations, are learning the lesson that this is how you keep yourself alive, by interacting with these short-termers. And then there's sort of also exploitation back the other way, right? Because, so that's sort of the community getting something out of this encounter while losing something. It goes the other way too, so clearly the organizations, institutions that make this their core are exploiting both sides because they're both using the community to construct this image of themselves as community-based, and they're also using these very well-meaning, well-intentioned, but naive groups of volunteers to extract revenue stream. So it's unfortunate because there could be good, sustained, high-quality ways of unsophisticated people providing service. There's not out of the question that one could have service programs for high schoolers or for college students or for whoever, church groups, that would be less unsophisticated than this. But we're missing the opportunity to think about what that means because it's just easy to do this. And I think the final point on this is that it's not really just a religious problem, right? Because, Guatemala is really interesting. It's almost now, it's the most Protestant country in all of Latin America. Catholicism is actually now the majority Christian sect in Guatemala. Most Guatemalans, indigenous and not, are Protestant, and mostly charismatic, really, really charismatic Protestants. And this is more the case in indigenous communities than in non-indigenous communities. More indigenous people are charismatic, evangelical, Pentecostal than are Catholic at this point. In non-indigenous, that's happening too, but to a less extent. So there's something very attractive to many indigenous communities about the charismatic Christianity. And part of what that is that there's a strong lay tradition in it, and that you go to any of these Pentecostal corner churches in a rural community in Guatemala, and the preaching is all in Mayan, and the hymns are all in Mayan languages. So there's the indigenous charismatic Christian experience in Guatemala is actually quite pro-indigenous. Right? So it's not just that, oh, this is a religious thing where missionaries are coming out and imposing their beliefs on indigenous people. It's more about that transaction of commodifying the experience of interacting with poor people. That to me is more problematic.
I'm wondering about what you think a good approach to get more first language services is, given sort of the fractious NGOs that deliver services.
So the question is, how do you provide more first language services? Because this seems sort of very, very critical. Because it goes both ways, right? If you can't have access to services in your language, you don't have good health outcomes or good whatever outcomes, legal outcomes or educational outcomes, and vice versa. If you don't have access, you lose your language because your language is disincentivized. So there's no straightforward answer. I think there are multiple answers, all of which we have to do all at the same time. The first is that we have to work on national language policy. This is an area that Guatemala has actually done pretty well in, and in some ways proves the limit of what national policy can do. So in the post-Civil War period, for example, bilingual education for monolingual Maya children is guaranteed by law, and all public schools in indigenous communities now provide at least in the first few years of schooling, provide Maya language education. You're guaranteed court interpreters in your Mayan language of choice, and in every community where Mayan language is spoken, the Mayan language is co-official with Spanish. So all state services in that community have to be provided in Mayan languages. And this is potentially just a paper law, but in practice it's often also the case. We work in many communities where if you go and have a meeting with the mayor, and the meeting will be in Mayan language. If you don't speak the Mayan language in that municipality, you're not going to be very part of the project. So I think there's been some progress there, but we clearly still see that doesn't trickle down to the level of certain kinds of services. So policy is important. It raises the symbolic status of the language, but practically it doesn't necessarily have the ground level effects that you need to have. So that's point number one. I think point number two is you have to empower community leaders with skills to stay in their communities and serve their communities. So I'm talking about, for example, indigenous doctors who are indigenous and speak indigenous language. There are not many, but there are some. And historically, the reasons that those doctors haven't stayed in their communities is because the groups who would employ them are unwilling to pay them anything even remotely close to what they could make by just not doing that. Right? So the development sector has got to start paying living wages to its Guatemalan employees, and this is something that's been very, very problematic in the post-war period with the Ministry of Health salary, for example, for a physician in Guatemala is about $1,000 a month. Not very much money. And many non-governmental organizations will pay that same physician. So we're talking about the more pro-indigenous organizations will pay that same physician, $300 a month. So, of course, they're not going to stay in the community and do community-based work. So it's incumbent upon people who care about this to pay indigenous staff a living wage. And then I think the third thing that's important at sort of the regional or the national or the international level is that we have to start holding, in the development community, we have to start holding each other accountable to the standard that language language and culture work is something that has to be in the planning stages of our programs. It's not something that can be just a minor technical appendix to whatever project we want to do. So, I don't know, let's develop an entire curriculum for teaching women about how to properly feed their children. Oh, shit, we forgot to think about how to do that in Kachukel. Okay, let's convene a little 2-day seminar and cobble all this together in Kachukel. Thereby missing the whole opportunity we had to craft not just the surface of the curriculum, but its heart, its core, its soul in a way that's compatible with local custom. This is obviously self-evident, but it flies in the face of the prevailing sort of international development trend, which is to develop big picture ideas that are applicable everywhere. And so this is the Bill Gates Foundation way. This is the USAID way. This is that what we want are heroes who change the game and come up with big novel solutions that we can plop down in Bangladesh or India or Guatemala or Kenya or rural China. And that will work everywhere. And this is simply not the way humanity works. This is not the way society works. And if we want to have solutions that are both more effective and that are more culture sustaining, we just have to accept the fact that development work is context bound, and that what works in Guatemala is not going to work anywhere else, at least not in its specificity. And maybe we can extract some ideas and some like basic principles that can be applicable elsewhere, but what we need is we need more specificity, not less. We need more context, not less. And we need more, basically, we need more people in health professions and in development saying, you know, I'm going to work in Guatemala for the rest of my life. And that's what I'm going to do, and I'm going to understand what that means. And I'm going to dedicate myself to being a good Guatemalanist, if you will. Or I'm going to work in, you know, pick your country, it doesn't matter. Right? This is not, this problem of, and what I think one of the take-home points from this little chat here, which I hope is useful to you, is that although I'm just talking about Guatemala, this is not just a Guatemalan problem. Right? This problem of marginalization due to cultural or language factors is universal. There are some 6,000 languages in the world, right? And half of them will be dead in the next 100 years. And it's because of this kind of thing. No, not necessarily. This is sort of very rough because this is very extrapolated data because there's no formal registry in Guatemala. So the way those data were calculated was sort of a density count. I would say that probably 1/3 of those organizations are based internationally. 1/3 of them are based in sort of urban elite Guatemalan society, and 1/3 of them are what we would call community-based organizations, which are sort of more grassroots organizations. She's asking what are the effects of stunting, intergenerational effects of stunting, which this is a whole talk, right? So I'll give just a very brief answer. We know that there are profound intergenerational effects of being malnourished in childhood. We know two things. First, we know that children who are stunted, women, girls who are stunted, become mothers who are at high risk for having small pelvic outlets and having placental insufficiency. So we know that being malnourished as a child, as a female child, when you become an adult or when you become pregnant yourself, it puts your fetus at risk of growth restriction and malnutrition. So we know that. We also know that being stunted as a child flips a switch in the way your genes are processed. Epigenetics is the technical term for this. That basically changes the way your body processes food. So your body becomes less efficient at processing especially fats, and your insulin resistance goes up, and so children who are stunted become adults who are overweight and have diabetes. So not only everyone says, well, what is this thing about like the fat mom who has a skinny child? Well, that's when she was the skinny child who became the overweight mom, right? So child malnutrition drives not only the cycle of poverty by producing more malnourished children in the next generation, but it also drives the cycle of adult illness by predisposing adults to heart disease, strokes, and diabetes. So really the entire cycle of illness and poverty is bound up in what happens in the first couple of years of life.
I have a couple of questions. Let me start with one and then showed a very nice picture about this family of part went to Florida and behind down. There's an article from the Scientific American that there's a recent article from Scientific American where they follow this tribe that's living in northern Mexico and essentially hunter-gatherers, and a picture of them. And then one of the tribes moved to Arizona, and a number of years later, there's a picture, and they're all equally line as tall. So they're so round, so the knees, etc. And this is a transition. So my question is whether the picture on the right is normal condition, or is another abnormal state, is another kind of spectrum. There is a very large study based in the University of Washington, probably funded by the university, and they follow essentially all diseases in most countries in the world for a couple of decades. And to summarize it in one sentence, is that diseases which help people get sick in what's called third world today, much more common by diseases like first world diseases, such as diabetes and lung. And it's not so much, of course, I don't know anything about Maya Guatemala, I don't know what diseases are common. Globally, coming year that the restful future is over
Yeah, there's a lot there. I'll just try to make a couple brief comments. So talking about, for example, why is it that, say, a tribe, indigenous people from northern Mexico go to the States and become obese quickly? There's definitely this, it's sort of a little controversial, but there's this sort of idea that in the U.S. public health sphere that this is a sort of a generational effect that you can see emerge, that in people from many Latin American countries, they come to the States healthy and then they gradually get less healthy over the decades. And there's certainly something there about coming from a place where maybe you eat less calories or you eat less calorically dense foods, or maybe you have a more active lifestyle and you move to an environment where you're not used to, where you no longer have that kind of lifestyle, that flavor of life. So it's pretty easy to see how you can get overweight in that setting, especially if you bring potentially consumption practices from another place. So maybe you're used to eating higher quantities of food, but now the foods you're eating are different and higher calorie. So you can see where that happens. There's also probably something going on with what I had described previously about sort of damage to children early in life, predisposing them to obesity and other problems late in life. And so if we have a population which is, was maybe a little malnourished during childhood, then they change the way they process foods. And so then if those people move to the United States or somewhere else, they may come with that sort of predisposition, but now with the access to these damaging foods that allows them to get quickly overweight. I think that's one thing. And then the other thing about why is it that non-communicable diseases like diabetes and hypertension are now occurring in poor countries. This is a very, 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 very important problem, which we're not talking about enough, because we're still fixated on HIV and tuberculosis and malaria, that 80% of deaths in the world from heart disease and diabetes now occur in poor countries. These are not diseases in rich countries, these are in poor countries. And what we're seeing, especially in places like Guatemala, as maybe an exceptional case, we're seeing, of course, all of the things that can cause heart disease and diabetes, like potentially more smoking, more drinking, more processed foods, less farming, more sitting around at a desk. All of those things, more urbanization, all those things are happening to some degree, but at the same time, people are being squeezed by the other side, which is that child malnutrition rates are not going down, right? So you have populations that are both being harmed by being starved as children, which then predisposes them even more to the damaging effects of overconsumption in adulthood. So, Mexico has, for example, as a good example of this, has a higher rate of obesity than the United States. Mexico has the highest rate of obesity in the world. It's exactly this sort of setup that does this, where you have a country that both has more food than it knows what to do with, but doesn't prioritize giving those foods to small children. So children come into adulthood ready, primed for disease, and then they encounter these foods, and then they get these diseases. So I think this is exactly what we're doing.
So, is there anyone else?
I didn't see anyone else raising their hand.
I was curious about, I guess, a lot of development NGOs, for better and worse, really thrive off of short-term influxes of human capital and the economic support that long-term lives those influxes, and the kind of cultural and linguistic competency and commitment to place and specificity that you're talking about obviously requires a lot more long-term commitment. So I'm wondering how in your organization you balance those two things.
Yeah, well, so the question is sort of how do you balance, needing fresh blood and the money that comes with it against, trying to provide more long-term sustainable culture balance solutions. And there's no good straightforward answer. I mean, I think a lot of the things that I talked about before about when you ask how do you increase first language services, I think we're talking about a lot of the same things here. Sort of slow organization, planning, strategic planning that you can build into the way you grow your organization that can protect against these things. And I think that, students in particular want this experience too. They just don't know they want it. And so that's what the question over here was good, because it's sort of, everyone is being exploited here, right? Because these people of goodwill who want to learn about the world and be responsible human beings are getting these really trivial experiences for which they pay a lot of money, and that's not good either. So we have to figure out ways to incorporate students or volunteers or supporters into our work in ways that's more meaningful and more long-term. I don't know how all of this works. I know in our organization, one area that we've been very successful is in providing mentorship to students, mostly not undergraduates, mostly graduate students or medical students, but also some undergraduates who sort of, we just set the bar a little higher to commit to being in Guatemala for longer. We don't really offer 2-week trips or 1-month trips, just come down for 6 months or 8 months or something. But you leave and you speak my language. or you're not trying, you know, and you come out of it with this sort of like in-depth experience in the community and the satisfaction of having plugged into a larger research program or development program that's ongoing, that began before you came and will continue after you leave, which I think in the end is way more satisfying for people. And so we think, you know, in our organization, I mean, all of us are sort of academic background, and part of what we're trying to do is train the next generation of global health leaders to think this way. So we think this is very important. We take this very seriously. Give students, emerging leaders, really high quality experiences that will motivate them to have long, engaged, and productive careers in global health. I think this is super important. I don't think we've always been successful. We certainly have students that were not good fits for us and for whom we were also not a good fit, but I think generally speaking, we've had positive encounters there. Now, how do you bring down a huge group of people in like tour a whole bunch of communities in a way that's meaningful and not boring? I don't have an answer for you there. That's not something we've done.
I had a question about how you select languages, how you go about teaching people in a reasonable time so that they can interact with it. Is it necessary that the physician himself or herself be the speaker, or is it okay to have someone who is close to the problem?
Yeah. No, so the question is like, it seems crazy that you're demanding that every physician in your organization speak a mind language. That's basically the question. And you're right, it is. Because at some point you have to balance the need for the medical talent against the desire to be sort of culturally and linguistically relevant. So I don't think it's the only solution. Obviously, having native speakers or highly fluent speakers as having your providers all be at that level is an ideal solution, but it's also not really the same. But thinking about how to improve the interaction is important. And so, when we have providers who don't speak sign language, which we have a couple of law providers who are wonderful people, but not indigenous, grew up in Guatemala, don't speak sign languages. They just shouldn't be alone with patients. It's pretty straightforward. All of our mid-level staff, all of our nurses, all of our health workers, all of our health workers, all of our social workers speak sign languages, and so just give them an interpreter. And try to train them a little bit on how to use an interpreter so that's an effective, using an interpreter is terrible. I don't know how many of you have had to work with an interpreter in like a really high-stakes setting like a medical encounter. It's terrible, and there have been some really interesting studies in the United States that have looked at physicians in the way they use interpreters in clinical settings, and including some really interesting videotape work where anthropologists desperate videotape providers with and without interpreters, with the cis or the trans language environment. And the most remarkable thing about the way sort of your average North American physician interacts with a patient that they don't share a language with an interpreter presence is that they don't use any body language. So the hands go in the lap. They don't lean forward. They don't look at the patient. They look at the interpreter. They use the third person. Doesn't matter. The patient can't understand what pronouns they're using, but the tone of the voice that goes along with using the third person is quite distinct. Then it comes back, what can I do for you today? What the provider says is, what can I do for them today, right? Or her today. And it totally changes the interaction. And so I think along with providing good interpreters when that's necessary, you also have to train providers how to use an interpreter in a way that preserves humanity in the encounter. And that's very tricky, but I think it can be done.
Have you experimented with telemedicine? Like having someone, depending on the people.
We don't have any shortage of
Not necessarily Guatemala.
Yeah, we don't do a lot of telemedicine, and we don't have any shortage of Guatemalan staff who speak, indigenous languages, so it's never a problem for even if the patient needs to interact with. And actually, a lot of our work is, accompaniment work where we, cancer patient needs chemotherapy or heart patient needs big surgery. I mean, obviously, I don't do that, right? So they have to go to this big hospital. We don't do that. They have to go to this big hospital. They go with a social worker who lives with them basically for 24 hours a day, make sure that all of their interactions are in, language that they can understand. And that works pretty well for us.
I work in Oaxaca, and our experience is that a lot of patients come with many of them are not speak Spanish for their kids. The children are often mechanical
We really try to avoid using families as translators because I think we sort of always felt that it puts an unfair burden on the family. And it also takes, we think of ourselves as co-constructing culture with our patients. We cohabit space with them. We're trying to create something exciting and new together. It's not just sort of pro forma anthropological dogma about accepting, prima facie the culture and experience of the patient. So a good example is we work with a lot of adult cancer patients who are in sort of palliative care, final stages of their disease. We very strongly believe that cancer patients should know they're dying, and we do not support in any way the cultural mores of where they're dying at all. Right? We're not anthropologists, so we can do that and get away with it. We very strongly believe that people have grief work and psychological work to do, and that's clearly my culture that I'm bringing to this encounter, but that's my feeling.
like talking to them in Spanish.
What's that?
That's like talking to them in Spanish.
Well, we don't, right? And so I am able to say to the patient, this is my feeling, as a doctor about what's going on. And with the presence of a neutral interpreter, we can negotiate something together. Whereas if you put the family in that position of being sort of in that bind of trying to negotiate between my culture as a physician and the culture of, you see, so I may be wrong, but there are encounters where there is a little bit of cultural friction, and we don't want to necessarily put the child at the center of that. So.
Have you been able to incorporate any traditional indigenous medications or healthcare initiatives from their culture?
So the question is, what about sort of indigenous health practices? And we strongly support this. A lot of our patients practice traditional sort of non-Christian Maya beliefs, and we really support this a lot. This is what patients want. We definitely support it. And in fact, we have some Maya which are the sort of shaman or daykeepers, as they're called, who work with us. We are able to provide, Mayan ceremonies for patients who request that as sort of part of their healing process. And we just actually, I just had this really wonderful encounter a couple weeks ago. We have a young woman who's dying of cervical cancer, and so this is sort of palliative care, and sort of requested a Mayan ceremony, and she did this, and this is really remarkable experience for her. I had been pain since I had the ceremony 2 weeks ago, and it was a very, very important thing for her. So we try to undo that stuff whenever possible.
Are there ever areas of friction between those medical practices and what?
So the question is about friction between indigenous medical practices and allopathic practices. No, I mean never. There are some things like this sort of thing which we do, which we like to tell people that what their prognosis is. So there are some cultural practices that we're clearly negotiating from time to time with patients. But in terms of suspicion of allopathic medicine. And we wondered if this would sort of be a problem when we started, and so this is why we tried very hard to incorporate mind healing practices, for example, to make those available to patients and things like that. But in point of fact, it ended up just it's never been an issue. It sort of always seemed that our ability to share with patients in their own language has been really the only barrier that was present in our patients. I would say the caveat is that we work mostly with Kachiko and Quiche speaking, which is sort of central, slightly more than some of the more remote communities of Maya and Guatemala. It's never been an issue. So it's always been, there's the shared sort of mutual trust that comes out of the experience of living in the same place and sharing the same language. And it's just never been an issue for us.
Le voy a preguntar en español, usted lo puede traducir. Con la experiencia que usted ha tenido en Guatemala, ¿qué es lo que usted sugiere para los médicos, enfermeras y las personas que trabajan en una oficina médica con respecto a este país multicultural en el que tenemos aquí? Yo, en mi experiencia, he tenido pacientes que han venido hablando el dialecto guatemalteco. Si la esposa habla el dialecto y el esposo habla español, entonces él es la vía para traducir. Entonces, yo quisiera saber qué es lo que usted podría sugerir.
Yeah, so sort of asking, what about, what about these sort of issues here in this country with all of its multiculturalism and the fact that, there are like 400 Commonwealth speakers in Champaign-Urbana. I don't know if you guys know that or not, but this is an enormous Commonwealth population in Champaign-Urbana, right? So what about, that wasn't part of the question, but I was sort of adding that in. So what about when you have these encounters here? It's super tough in the United States with minority languages, right? Because I run into this in Boston too. Boston, the former Boston City Hospital, right, which is the public access hospital in Boston, has on an average day, speakers of 85 languages coming to the door, right? And eventually you're going to run into a situation where there's no one on the blue interpreter from that speaks that language. It's just going to happen in this amazingly complex, diverse society that we have in the United States. So I don't have an answer for the Commonwealth patient that comes in to your office in Champaign-Urbana because there are no other Commonwealth translators other than their husband or their daughter or their son. But I think we have to at least be aware of the traps that using families to interpret. We have to know what we're getting ourselves into at least, and not be naive about the bind that puts family members in, and also not just not overestimate the reliability of what we're getting out of that encounter, and try really hard to figure out how to preserve all of the human elements that we're going to forget to engage when we get nervous because we don't understand what the patient is saying, right? So at least make it a kind encounter. Use the right body language. Look at the patient. Lean forward. Engage them. I think using the same pronouns that you would use if you were speaking in the shared language is super important because this is really the case. Most physicians especially don't, when there's an interpreter in the room, not only looking at the interpreter and not at the, sort of like, I'm talking to her, right, but I'm talking to you because you're the interpreter, so how does she feel? Right? So I'm just going to keep talking to you. And then I would say to you, can you ask her how she's doing today? Right? So ask her how she's doing today. Okay, now, how are you doing today, right? So he can hear me, I don't have to look at him, right? And using you in And it changes the whole tone of my voice because it psychologically engages me with the patient in a way that going through you as a sort of technical interface doesn't. So this is super difficult, and I think we just need to keep reminding ourselves that this is what happens when we don't have access to this rich primary first shared language experience, that all of the real quality of the encounter is evaporates quickly, and you have to try even harder to reinsert it. But I don't have a good answer. It's really hard.
Can I comment about what you said
Yeah.
about the why being so again, I find it fascinating that there is this mix of extremely pro-culture, Mayan culture, mental rhythm, coupled with this very, very Western view, cultivation now. This is very, very foreign in many cultures. The other part is things like the education and education is so reassured. The pattern of system is there, so much more. It's sensitive. It's very, very sensitive. Very thinking. And so again, I'm a little surprised that in the process, some things like highly resistant.
No, and I specifically injected this example because I know it's sort of controversial. I'm trying to show that we're sort of figuring this out, and there are elements of it that are highly inconsistent, and we're co-creating something here with the people we work with, and we're trying to be very aware of the values we bring to it. And this is I specifically use this example because I know that it's controversial and that it's not very tasteful.
The United States basically sue you because you told them they had their images on the system, right? But that will never happen anywhere else in the world. Very happy with it. That's and then again because of the need, there's so much over the world. It's so natural to use
No, and I appreciate this, but I'm not in any way arguing with you. I recognize our own inconsistencies in the model, and that's sort of part of, I think, the process of where we are with it.
I just wanted to respond to that. I think there are other issues, or I wanted to challenge the idea of family members being actual interpreters or translators, because apart from the unfair burden of putting them in a position where they need to be a neutral communicator, but they're not a neutral party to this conversation, there are also technical issues. Interpreting isn't just the issue of being bilingual, there's technical competencies to be able to reliably convey information. And it's not only unfair, but it's unrealistic to expect that of any given family member, especially when in this country, as you mentioned, they're often minors.
This is, we could obviously, this is an amazing, very, very critical discussion. That could be going forever, but that's not.
One comment or question, I guess. I think you're a rare physician or doctor. My experience, listening to you describe your role as a physician and dealing with your patients, it seems like you don't place any higher your profession as a doctor above and beyond the language or the culture of the individual people that you're serving, where many times the medical profession or doctors tend to put their profession, how they cure, how they can help people, that's it, and the most convenient, most efficient, effective way of doing it, regardless of culture or language, is how we've got to do it. And so I basically have two questions, because I really see this almost being an intractable sort of problem. I don't know in the long term how it works out 50 or 60 years down the road. And the question I have is, when you go around and talk to other physicians or medical organizations and you explain what you're doing, what type of responses do you get from them in saying, oh, we as doctors have a responsibility also preserving culture as we serve the medical needs? Because I would think most people would say, I'm not going there to learn it or spend the time or the additional cost to do it. And then the second part of that is, it seems like medical services to citizens of a country should be the primary duty of the national government of that country. That you can't rely solely on, outside people, even though that may be necessary at this point in time. So my second question is, can you perceive a time when the Guatemalan government will actually recognize minority indigenous groups as being entitled and to the same rights, same dignity, the same sorts of services that the majority population and the majority language population gets? Because I see just the opposite happening in countries around the world. How does that? So there's kind of two questions there.
So the first question is sort of, what response do you get when you talk about basically making medicine somewhat subservient to higher goals, or whatever those might be? And that's certainly definitely been what we had wanted to do, is to try to think about, why are we doing medicine in Guatemala? We're doing it because that's what we know how to do. But it could be anything else. It could be building roads or teaching school or whatever it is. We just happen to be doctors. So this is the way that we can support what we perceive to be higher goals, human goals about language preservation and about mutual negotiation of what it means to be human in this weird international space. So it could be anything else. I think, potentially one of the things that makes medicine a little unique is that it's super high status. And there are not very many other domains of language use that are as high status as medicine. So if you can provide medical services in indigenous language, you're saying a lot about the status of the indigenous language, and it's highly symbolic value. So strategically, potentially, it's maybe one of the more important areas to apply pressure. But I can see law being another one, for example. Big technical disciplines with a lot of human impact that could sort of really elevate the status of indigenous languages. And I think that the responses we get mostly are pretty positive. They're not sort of like, that doesn't make any sense, or all I want to be is a doctor. It's more about, not thought of that before. It's, I think the big pressure in development work is to do development and at whatever cost, with responsibility to stakeholders or to donors or to reporting requirements, and some of these things get lost. But I think they resonate with people. So I think it's just a matter of talking about it louder and longer. Hopefully we can create a community. And then I forgot the second question. Sorry. What was it?
The national government.
Oh yes.
Serving.
Yes. So why isn't it the job of governments to provide health care to their citizens? It's certainly part of the sort of democratic consensus, but it sort of seems these days that the democratic consensus is a little old-fashioned. Doesn't mean that it's wrong. It just doesn't exist anymore. The structures that gave birth to it seem to be going away quickly. Guatemala is so privatized. 75% of healthcare expenditures now are out of pocket. When people ask me what does the Guatemalan healthcare system look like, I say it looks exactly like the United States healthcare system. It's exactly the same. All privatized, all fee-for-service, all chaotic, with this vestigial little public health service that does a few tiny little things like, gives out drugs for tuberculosis. So it's hard to say. This is certainly not the case everywhere in the world, but it's hard to sort of say in that sort of neoliberal post-war boom of outsourcing and privatization. That seems like a one-way road to me. I'm not saying that that's good, but I don't think it's a reversible process. It's hard to see, at least for me, how it's reversible. I'm not very sophisticated about these things, so this is not like I know what I'm talking about. This is sort of, it's hard to imagine, imagine the U.S. going to a single-payer plan. How would that happen? Right? And so when you say to someone, how would the U.S. go to a single-payer plan? To me, that's exactly the same question as saying, why doesn't the government of Guatemala pay for health care to citizens? Because they seem very similar, like some similar constellations to me, although, the bottom of the barrel is farther underwater in Guatemala. People are further underwater, but the general constellation of the players and how they interact with each other is very similar.
And how, long term, down the road, 6, 7 decades, do you foresee any change moving in the direction that you're suggesting or proposing, or moving to, these cultures need to assimilate, these minor languages are better off because it's going to be more efficient? The larger forces, that play within a country, even like ours, single payer is very unlikely. How do you, is that transformation, feasible in some way?
Yeah, I mean, I think
relevant in terms of what you do day to day.
I think that the thing is that the sort of neoliberalism and what it's done to us is, especially in healthcare, is horrible in so many ways. By taking social risk, which is spread over populations, and dropping it onto the head of a single individual, to make this unsophisticated patient now a healthcare consumer who is responsible to the market and it bears all of the financial health risks of purchasing decisions that they have to make without any support and guidance. That's the horrible dynamic of healthcare privatization. The good dynamic of it, if there is a good dynamic, is that it does potentially, I don't know, there are at least some people who feel like it creates some wiggle, some sort of weird third space where social change can happen. And it's it's extra governmental change. But you see this happening in Mayan communities that are, now 15 years after the war, are reorganizing in really vigorous ways. I haven't seen in 10 years, very recent stuff. The fact that there are, this doesn't have anything to do with healthcare, the fact that there are punk rock bands in Cachitel is really exciting to me. The fact that there's a movement among Mayan youth who are legacy speakers, this third generation that never learned their language, and now are, learning it basically as a second language, is really encouraging to me. So I think there's this, when the state evaporates, lots of terrible things happen, but potentially some good things can happen around citizen organizing. And I'm not saying that this is better. It's better to live in this weird privatized environment, but it's what we're living in. And we have to figure out how to organize and how to build communities in this new place that's marked by chronic insecurity and rising costs of living and unemployment. I don't have an answer, but it seems like there are good things and bad things happening. And, I know I'm not answering the question, I'm just rambling around this point. It's hard. It's a really hard thing. But I think at least my intuition is that it's not all terrible. That there is hope. And whether there's hope or not, we can't go back to where it was. We have to move forward. And the one thing that's different is that that's different now in Guatemala from 20 years ago is that there's this enormous mobilized group of really engaged, motivated citizen leaders who are working really hard on behalf of their communities. and doing so at least without the threat, mostly without the threat of physical death. That seems good to me, and not ideal, good. Seems like we have to focus on what we can accomplish in that space at least. This is just sort of the barefoot doctor perspective. You know, there are clearly like big policy things that we have to be working on as well. But I think we shouldn't pass up an opportunity to do good, effective community organizing just because the stages of outbreak are around us. But I don't know. You guys are probably much more sophisticated about it. I'm just a doctor, right? So,
How much of the population is made up of indigenous Mayans?
well, really, so how much of the
Do they
population
have
is
the
indigenous?
political
Yeah.
power if they?
It depends on
vote?
exactly, right? This is the thing, right? Exactly. This is what you're saying. See, exactly. This is why you need to be having this discussion on me, because that's exactly what I'm trying to say with my 5 minutes circumlocution is that it's like 80% of the population.
Yeah.
And they're all like running these little organizations and working really hard on behalf of their communities. And if we can do that together, that's a powerful extra governmental force to change, despite the fact that food costs are rising and the police are criminal and all these things. So.
Go ahead.